So I'll call to order our Standing Committee on Public Accounts for Tuesday, January 28th. We do have some folks joining us today, and so I'll just read the mandate and the statement of purpose and values, and then I'll introduce our guests that are with us, and then we will move on to the number 3 on the agenda. So I'll call for an adoption for the agenda as it currently stands. Natalie? And I don't need a second. No. All right, so our mandate. The Standing Committee on Public Accounts is charged with matters concerning the public accounts of the province, the annual report of the Auditor General, and fiscal management. Statement of purpose and values. The Standing Committee on Public Accounts is dedicated to improving public administration in partnership with the Auditor General. The committee examines the administration of government policy, not the merits of it. The committee strives to achieve consensus in its decisions whenever possible. Members take a nonpartisan approach to the work of the committee. So I'd like to start by welcoming our guests today. We have Denise Lewis Fleming, the Chief Executive Officer for Health PEI. We have Andrew MacDougall joining us today. He's the Director of Long-Term Care for Health PEI, as well as Calvin Joudrie, Program Management for Long-Term Care, Health PEI. And so I will turn it over to you, and I will let you take it away.
Thank you for the invitation here today. Good morning, everyone. My name, as mentioned, is Denise Lewis Fleming. I want to thank the members of the Standing Committee on Public Accounts of the Legislative Assembly for the invitation to appear here before you a second time. Joining me today, as mentioned, are Andrew MacDougall and Calvin Joudrie. I would also like to acknowledge Jamie MacDonald, the Chief Administrative Officer responsible for long-term care, for her contribution in preparing for today's presentation. She was also a key member in putting together the information we'll share with you today. As I stated when I last appeared before the committee in October of 2019, I do acknowledge and fully support the oversight role of this committee, as well as the role of the Office of the Auditor General in ensuring accountability for the appropriate spending of taxpayers' dollars. Today, we're here to discuss the Auditor General's 2016 report on payments to private nursing homes. And in particular, we are going to highlight all of the recommendations, but I know the interest is on the recommendations that are still outstanding to be completed. So before we get into the audit, I would just like to provide the committee with some background information on our long-term care program and the role of private nursing homes in that program. The program provides a home to individuals assessed as needing 24-hour nursing care. The home may be publicly operated or a licensed private nursing home. Private long-term care homes are licensed under the Community Care Facilities and Nursing Home Board and are inspected by the Department of Health and Wellness staff to ensure they meet or exceed the minimum standards of care requirements as specified by the board. And the board is administered, in this case, through the Department of Health and Wellness. Before someone is eligible to live in a long-term care home, they must be assessed to ensure they require 24-hour nursing care. We do complete the assessments using the Seniors Assessment Screening Tool. And that tool assesses the amount of help a resident needs to perform their activities of daily living, as well as what their ailments or conditions may be and what their medication management needs are. So those tools, as some may be aware, rates a person's needs on a 5-step scale, 1 being you're totally independent and 5 being totally dependent. A score of 4 or 5 is required for a person to be eligible to enter into long-term care. Once a person is eligible for entry into long-term care, their name goes onto the wait list, and then if they move into a private nursing home, Health PEI makes payments to that long-term care nursing home on the resident's behalf for their nursing care. What is separate is then what happens for their accommodations. So the services the long-term care home provides and the remuneration the operators are entitled to receive are prescribed in a signed contract with the Department of Health and Wellness, which Health PEI administers. The contract is titled An Agreement Respecting the Long-Term Care Program in Private Nursing Homes, and specifies the rates that the facilities may charge for basic health care, accommodations, and other related services. Health PEI provides monthly payments to all private nursing homes, subject to the Long-Term Care Subsidization Act and the terms that are within that service agreement that every nursing home has signed. So as you can see, Islanders have access to 10 long-term care homes on PEI. There's 10 private operators, I should say, but there's 19 long-term care homes across PEI for a total of 1,203 beds currently. Admission is coordinated by Health PEI, and we aim to ensure that there's fair and appropriate access to the 9 public manors and the 10 private long-term care homes. The private facilities are currently licensed to operate 608 long-term care beds, which is approximately 51% of our total long-term care bed capacity on PEI. Private nursing homes are an essential partner in providing services to some of our frailest residents on PEI. For these services, private long-term care nursing homes receive room and board payments directly from each resident, as well as monthly payments from Health PEI related to services, healthcare services, as well as accommodation payments for residents who have qualified for a subsidy under the Long-Term Care Subsidization Act. In 2018-2019, Health PEI paid out a total of $27.4 million to private long-term care homes. This includes approximately $5.9 million in accommodation payments on behalf of residents who qualify for a subsidy. So those are individuals who their income is deemed insufficient in order to pay for that amount themselves directly. So I hope this information I've shared provides you with the necessary background to support our discussion on the 2016 report by the Auditor General, which is the focus of our appearance here before you today. So the 2016 Auditor General's report was an audit of payments made by Health PEI to private nursing homes. The Auditor General noted, overall, this program area was included in the audit as it was important for Health PEI to protect the interests of frail elderly, and the public dollar amounts paid to the private nursing homes is a significant amount. The stated objectives for that audit were to determine if my organization had the appropriate processes for reviewing and approving claims from private nursing homes, assessing eligibility for accommodation subsidies, and monitoring and reporting on long-term care subsidies. So it's not on monitoring their compliance with standards for the delivery of care. This is in relation to the payments for those particular pieces. The audit did highlight areas of concern and weaknesses in some aspects of the long-term care subsidy program and our compliance with all regulations within the Act. But before I focus on those resulting recommendations, I did want to highlight what I think is important. The audit itself did include a statement that overall they believe Health PEI has appropriate procedures in administering the assessment and approval of applications for long-term care subsidies. So these recommendations were really some areas for us to improve and focus on, but overall, I was quite pleased with the finding that in the whole, we have appropriate procedures in place. So the Auditor General highlighted 3 areas of concerns. The nursing home claims review process was one. The claims review process includes a standardized monthly electronic submission from each of our private nursing homes to Health PEI. The submission, that's not coming out well, was a detailed account of all services rendered by the facility that were eligible for payment under the service agreement. So we do receive it on a by-person basis. The audit conducted reviews on 50 client files. Errors were found in 3 of those 50. So of their subsidy calculations for over the 10-month billing cycle audited. For the perspective, the audit did note that all health care and comfort allowance calculations were correct. This means that approximately 1,200 correct calculations associated with the processing of the nursing home claims on those 50 clients for that 10-month period were correct. Now, a third area that was highlighted by the Auditor General was Health PEI needs to conduct annual subsidy reviews on all eligible residents as required by the regulations. So the regulations do require an annual review of all subsidized clients. Prior to the audit being conducted, the long-term care program manager indicated to the auditor that Health PEI, we do recognize, was not in compliance with this regulation due to staffing limitations. To ensure our limited staffing resources were able to focus on priority areas, we took a risk-based review system and put it into place in 2007. So what we do is, on our staff's initial assessment, the client who had income sources that did not vary are provided with the option to sign a contract agreeing to have their pension checks paid directly to the nursing home. So there are some incomes that change very little. Canada Pension Plan, Old Age Security. If they agreed, and that was their sole sources of income, they were deemed to be low risk and were not placed in the queue for annual reviews. So we very much took a risk-based approach and wanted to say, who are the ones that we have to make sure they really do need to be checked for eligibility for subsidization, because there could be more variation. This approach, though we recognize not compliant with the regulations, allowed staff to complete financial assessments on new residents entering care and focus completing annual reviews on clients where there is a higher risk that all of their actual income may not be going towards their accommodation costs. For perspective, in 2018-2019 fiscal year, there were 869 long-term care residents receiving an accommodation subsidy. Staff completed 479 new assessments for residents entering long-term care, and 202 annual reviews of existing subsidy clients were completed, which leaves approximately 200 clients who did not receive an annual review because they were in the low-risk group. We do recognize, given our approach that focuses on annual reviews of high-risk clients, we are currently not compliant with the regulations. So the third area that the Auditor General focused on as an area of concern was public reporting as required by the Long-Term Care Subsidization Act. So since that time, and even earlier, Health PEI has compiled annual reports on the Long-Term Care Subsidization Act since the fiscal year 2010-2011. As these reports were not tabled in the House, that is what led to the notation of non-compliance. Given this context, I'll now move into reporting on the recommendations stemming from the audit and the steps we have taken towards completing it. So the audit did result, as you can see, in 7 recommendations. We do, as I mentioned earlier, acknowledge the benefit of implementing these recommendations in an effort to ensure that we have appropriate mechanisms in place to protect the interest of frail elderly and to ensure that taxpayer dollars are being appropriately spent and overseen. We are striving to be fully compliant with all recommendations by December 2020 at the latest. 2 of the recommendations we implemented immediately after the Auditor General's report was made available to Health PEI. We also developed a work plan to implement all the remaining 5 recommendations. On the AG's initial follow-up, they accepted the work we had completed on an initial 2 recommendations, and they do continue to follow up on the recommendations that would need work to be completed. The initial feedback on that first recommendation that we completed and they audited, they did note that the work effort required to comply with that particular, or given feedback we received from them, and noting the work effort required to complete that particular recommendation, we revised our work plan. There are a number of factors that have delayed us in completing this work, and I will provide some context as I report on the status of each recommendation. To date, we have fully implemented 1 additional recommendation, so there's now 2 complete, which the AG is currently auditing the second one. We will be compliant with the recommendations on trust account reviews, as well as appropriate documentation to verify an applicant's income once new regulations come into force. The final 2 recommendations require changes to the regulations to be in effect so that we can adjust our workflow to ensure that all cases are reassessed on an annual basis and that we consistently apply the medical transportation policy. Finally, the Long-Term Care Subsidization Act is also in the legislative work plan for the Department of Health and Wellness for the upcoming legislative session. We will require some updates to that act in order to also be fully compliant with the Auditor General's recommendations.
Yep.
So areas needing improvement, which we have implemented, as you can see here. That first initial piece that we worked on, the audit highlighted errors in the monthly claims paid to private nursing homes. As soon as we received that report, we implemented a more robust claims review process that has been accepted by the Auditor General's office and has been in place since then. The second piece, reporting annually on the administration of the long-term care subsidization program. So on receipt of the audit, we immediately took steps to table the reports that hadn't been tabled since 2010, and we then take steps to ensure that they are then tabled annually since that particular piece. I know we've recently completed last year's
18-19.
the fiscal year 18-19's report and are sending it to the department for them to bring forward to the House to be tabled. On areas that need strengthening, the first one that we completed and is now under review is conducting and reporting on case audits. We immediately undertook a process with IT Shared Services to develop a case auditing capacity tool and to have it available with the ISM Long-Term Care Subsidization Program. So that is the system where we keep our documentation with relation to our long-term care residents. The functionality was completed and put in place in late 2017. 30 case audits are now conducted annually, and a report on these audits is now included in the draft 2018-2019 annual report, and it is our intent in all the reports going forward that we would include information on the case audits that are done every year at a summary level without disclosing any personal health information in relation to that. The Office of the Auditor General is currently auditing this work to ensure that it complies or aligns with their recommendation on the reporting. So, recommendations that we are aiming to have implemented by February 1st, this coming weekend, relate to periodic review of trust accounts and maintaining adequate documentation. The periodic review of trust accounts, while they are not required in the Act or the regulations, Health PEI recognizes that annual reviews of trust accounts align with our role to protect the interest of the frail elderly. So those trust accounts are made available to individuals who receive a subsidy, since all their income is going towards paying for their accommodations. They're left with what we refer to as a comfort allowance in order to pay for some incidentals and help with them purchase a few things. On receipt of the AG's report, we immediately developed an audit plan to do a detailed review of trust accounts. The plan was to do an audit of trust accounts for 1 or 2 private nursing homes each year. This work was undertaken and was audited by the Auditor General in 2018. The Auditor General accepted the approach that we laid out, but they recommended that the frequency of the audits was low, and they would like to see, as it would only be every 5 to 10 years that a nursing home would be audited. So, given the amount of work effort to comply with the frequency requirements and the Auditor General's recommendations that a review instead of an audit would be acceptable, we have developed a new approach. The revised regulations require the administrator of each private nursing home to report on the trust account transactions for each resident to be reported to that resident or agent or their agent annually. Health PEI has developed a schedule to review each home annually to ensure that they will be in compliance with this new regulation that we want to be put into place. So those new regulations that we're referring to here, we have brought forward to the department, and they are bringing forward those on our behalf in order to have them proclaimed. This, we believe, will allow for more transparency to the resident or their agent, as well as to Health PEI, that their trust accounts are being appropriately utilized. So the second recommendation is maintaining adequate documentation to support the applicant's income. and ensuring it's verified in accordance with the Act. If you've taken the time to review the current regulations, you will see they require Health PEI to have a copy of the CRA Notice of Assessment for the last 2 tax years and a working copy of the tax return for the most recent tax year as a minimum documentation needed to complete a financial assessment. The AG determined we were not in compliance with this regulation as assessments were completed on a number of clients who filed their taxes electronically and therefore did not have a paper working copy of their most recent tax return to provide to us. The revised regulations remove the need for a working copy, paper copy, of the taxes as part of the needed documentation. Therefore, our current process will be compliant with the new regulations. For the committee to be aware, we do have arrangements with Revenue Canada where we can receive access to their electronic file of what they have filed for their tax assessment. So we do have the pieces electronically, just not the old paper files that the regulations were built upon. So the next area that is still needing improvement and recommendations still have a work plan in place. The first is in relation to the transportation expenses for subsidized residents in accordance with the policy that Health PEI has. So Section 1C3 of the Long-Term Care Subsidization Act defines financial assistance to include payments of pre-authorized health-related travel and transportation expenses. So the Auditor General found that medical travel claims for subsidized residents were inconsistently applied across the province. Some areas we paid for pre-approved medical travel and some we did not. In Queens County, the transportation expenses were handled in accordance with the Act, while residents of Prince County and Kings were still subject to the practice on medical transportation that existed under the old regional health structure. So some of those differences arise from the differences in funding that had been provided to the different regions. Health PEI implemented this recommendation for subsidized residents in all private nursing homes across PEI in April 2017. So we would consider this recommendation partially implemented. It's being consistently applied for all of our private nursing home residents. What we are still working with the department is the policy on how to implement this practice across all public manners. So it has some cost implications, and it also requires some clarification in the Act itself on defining what medical transportation is. Because what is an insured medical transportation? What is perhaps an uninsured medical appointment, for example, if you're going to dental appointments, which are not traditionally part of insured services. Getting those clarifications in will be important for us to say, how do we make it fair and equitable for all? So currently we are working with the Department of Health and Wellness on the next steps about getting the clarification we need for the medical transportation policy and that definition. And the department on our behalf is taking it forward to government. Once we have that clarity, we will be able to work further on what we need to implement this on the public side. But as far as for the private nursing home side, it is consistently applied. Conducting the annual review on all subsidized residents to comply with the regulations is another final recommendation that will be still pending. As discussed earlier, due to staffing limitations, Health PEI has used a risk-based system to prioritize which clients should receive an annual review. The new regulations will still include annual reassessments of clients, and Health PEI does aim to comply with this requirement this calendar year. Currently, the average assessment takes approximately 2.5 hours per client. Once the new regulations come into force, the changes to the consent process, the elimination of the need to have the working paper copies of the taxes, and the introduction of how we do assessment, a change in how we do assessments to be more fair to spouses living in the community while their spouse enters long-term care, will significantly streamline how much time our staff has to spend on those initial assessment processes. This will then free up time for our staff to do the annual reviews. Health PEI has engaged with ITSS to make changes to the electronic intake process. Once completed, we estimate the average assessment should take 1 hour or less. So we're cutting it by more than 100%. Well, more than 50%, I should say. Freeing up time to complete our annual reviews. There are 3 changes to our digital workflow that will need to be put in place before our full streamlining can be consistent with the new regulations. First is completing the implementation of the revised intake and review process in ISM, as I mentioned, our system where we document all our information on our private nursing home residents and our public nursing home residents. Changes to the ITSS processes to allow for batch queries to Canada Revenue Agency for all of our clients' notice of assessments, so that we don't have to go in on a one-off basis. That takes more time. Doing batch queries will go much faster. And automatic uploads of digital CRA data into our clients' ISM subsidy reassessment. That's how we're going to get some of those time savings to move forward. Early discussions with the IT Shared Services Manager responsible for our ISM system and for the CRA query tool seems to indicate that this work are required to complete the first 2 changes can be completed by this fall. So it does require some programming work to do that piece. The final changes need to be fully investigated to determine if it's cost effective as far as the automatic uploads of our digital CRA data. Assuming that automatic uploads cannot be implemented, we estimate the time could be reduced to approximately 1.5 hours. So we're aiming to get down to 1 hour to 1.5 hours from the current 2.5 hours in that assessment. And this additional staff time will be redirected towards completing those annual assessments on all client files by November 2020. So by the fall, getting our electronic pieces in place. Hence the reason earlier I said we aim by December 2020 to have completed all of our recommendations. Health PEI will continually assess the impact of this approach to determine if we are successful. If the process does not afford us the ability to complete the annual reviews, we'll pursue the ability to automatically upload data, ensuring we're able to complete the reassessments. And if we still face challenges, then we will have conversations with the department about how do we resource appropriately the balance that we need to conduct those annual assessments. I want again to thank the committee for the invitation to appear before you today. I hope the information I've provided helps you to have additional insight into what our efforts have been to implement the Auditor General's recommendations for strengthening our processes for payments to private long-term care nursing homes and improving our long-term care subsidy program. So this concludes the formal part of my presentation. We'll now take any questions you may have, and I may have to call on Andrew or Calvin to respond and provide some additional information. Thank you.
All right, so questions? Go ahead, Carla.
I'm just wondering how much Health PEI will be allocating to accommodation subsidies for the operational budget of 2019 and 2020.
So those discussions are currently underway in the management plan, and then we'll have to flow through that particular piece. We always look at what our current year budget, do a projection forward for what our residents may be. We always look at who's subsidized versus who's not. So I won't have a dollar for you right now, but that will come through the management plan
So that's
process.
something that's always changing.
Yeah.
Based on. And so to what extent can Health PEI audit the private long-term facilities to ensure that subsidies are being properly spent on accommodation?
Okay.
Go ahead, Calvin.
Sure, it's Calvin Joudrie. So what we do for our process, every month we get a report from the long-term care report from the private nursing home, and it itemizes the amount of money that they collect from the residents. We check that with our ISN system to make sure the payment is equal to or greater than what we've assessed in ISM. If there's a difference, we go over to the site and ask what's going on, or we check with the family and do the assessment. So we do an ad hoc review every month on every nursing home to see if the totals make sense and the accommodation columns. And if they do, then we are fine. If they're not, we do further investigations. It's important also, to your earlier question, each resident's accommodation is based on their income, so the amount of subsidy that is required every year is dependent on who's in long-term care and what their actual income is, so that's why there's variation.
Okay.
Carla?
So what about subsidies for comfort expenses?
So that's the review of the trust accounts. So the comfort expenses is the trust account.
Okay.
And that's the work that's being put in place through the new regulations to improve the reporting on that. And then that comes to our office, and we'll be doing periodic reviews of the nursing homes.
Okay.
Carla?
So what is the formula for determining how much subsidy a resident receives?
Okay, it's Calvin Joudrie again. So what we do is we look at line 236 of their most recent income tax year. We take that, basically divide it by 12. That's their annual or their monthly income. Then we look at that and see the difference between that and $92.10 a day times 30.42, which is the average number of days in a month. If that number is equal to or less than their income, well, then they qualify for a subsidy. On that qualification, they get the difference between their actual income and that dollar value, and $123 per month in a comfort allowance.
Impressive math brain. How recently has Health PEI reviewed the income criteria for determining who is eligible for subsidies, particularly given the recent increases to social assistance rates?
So we do review it on a periodic basis, and it's the conversation we've been having with government. In particular, we've also been focused highly on individual or couples that have a spouse that remains at home and a spouse that is going into long-term care. So the most recent review actually was this past fall to say what is an appropriate minimum level of income that should be retained by the individuals. So it's periodic, but that's the most recent one.
And so the...
Carla?
Sorry, Chair.
That's okay.
The most recent, so the increase in social assistance rates wouldn't be applied yet.
We looked across government as a whole as to what were the different minimum income thresholds used for a variety of programs. Social assistance is one, yeah.
Can I speak?
Yep.
So reality is the social assistance rates that apply underneath the Long-Term Care Subsidization Act are automatically within our calculations with an ISM whenever we do a review of income for a couple, because there's a process called variance. So we look at the expenses, and the expenses that are related in social assistance that are applied to our act are automatically updated as those numbers change. What Denise is referring to is where residents in long-term care are seen not to be equal to social assistance, but to have a reasonable standard of living. We also allow for other expenses to be calculated so we can ensure that the spouse living at home can be reasonably cared for in their home as opposed to being forced into other scenarios. So that's the process that we're currently reviewing with government to see if there's a better way of doing that, because the variance process right now requires a lot of receipts and a lot of detailing what those expenses actually are so we can complete the file. So we're trying to streamline that, and that's what we've actually reviewed this fall.
Carla?
That was actually one of my later questions was on when there are two incomes involved or two people involved, one in care and one not. And I was just kind of wondering about the consideration for the spouse not in care. So that is all part of the process.
Very much.
Yeah, okay. I'll let anyone else who I have more, but I'll wait.
Thanks, Carla. Rob?
Yeah, I got a number of questions too here. So when it comes to the comfort allowances that is left remaining in the accounts, I mean, there's some people that probably don't have a lot of capacity to use those funds and stuff like that. Is there any situations where the comfort allowance does not get used, and if so, where does that money go? Does it build up until they might use it, or what? Can you explain that process a little more clearly?
Sure. So under the policies, the comfort allowance is used for the residents' personal use or the expenses they need for little items that the family can provide for them and provide the receipts to us so we can account for it. At the end of the day, when the person passes on, the balance of that comfort allowance after the expenses that were incurred in the facility are taken care of goes to the estate of the resident. So it's not recovered by government, it goes to the resident's estate.
Rob?
Is that accrued like annually it builds up, or is it monthly, or you know what I'm saying?
It's accrued from the day that they go in there until they pass away.
Okay.
I'm just is on?
You're just talking to him.
Talking to it.
Don't get that close to the mic there.
Andrew MacDougall. The other thing to add on that is, so comfort funds are held in trust, and so they're deposited by the facility, and the interest that does accrue on them, the collective interest, I guess, from all the trust accounts that accrues on them does become available for the general benefit of residents. There's been occasions where we'll use that for comfort-related elements, whether it's to buy supplies or it's equipment or programming. So we'll use interest income off that for that purpose.
Rob?
When you mentioned the differences in the travel expenses that are accrued to residents in long-term care facilities, is that different between public and private? And how soon will this be rectified, I guess, as far as Prince County different than Queens County? I have a few more questions on that, but just maybe start it off with that.
So as I noted earlier, currently there is a difference between public and private. We are consistently applying the medical travel policy on the private side. We have some inconsistencies based on what funding is available across the public side. That is currently with the department, and they're bringing it forward to government. We would really anticipate no later than this spring, we would like to have it resolved, but it is something that is before government's consideration, and it may have to be taken into account in the legislative work plan in order to address it.
Rob?
So one of my issues that I tended to incur a bit as a previous minister and as an MLA is those residents that are in Prince County facilities or whatever, a lot of I'm not saying a lot, but there's lots of cases where their services are required in, say, Charlottetown. So is there something that sort of weights the amount of funds that are available for those that are having to travel farther to get a particular service than those that are closer to the service? So in other words, is it not so much every month for everybody? Is it a little more for the ones in Prince County and, say, Kings County, or is it based on any kind of need? How is that figured, or will that be calculated?
Yeah, the policy as it exists right now does not weight based on where you're located in that particular piece and where the transportation. I know there's various options that have been looked at by Calvin's group as far as weighting, distance, and so those are some of the options that we put forward to government to consider.
Rob?
Don't you think that it should be made to either have some sort of a process to wait for those residents that are, say, in Alberton to have to get services, even in Summerside, they're going to have to travel further, which hence there's a greater cost, which might be a different fee for them to pay friends, family, or what have you to get them to those places. So I would think there to be some sense of fairness to all of Islanders and across the province. We should be looking at either on a per kilometer basis as something that sort of, like I said, weights it or makes it fair to everybody, so residents are, regardless of where your location is, because sometimes you don't have a choice in where you go based on available beds, so that can have an impact. So say, as an example, you mentioned the dentist issue. So if you're a resident of, say, the O'Leary area and you wound up having to take a bed at Parents Lodge and I guess in the border of Prince County, I can't think of the name of the community, but to get to their regular dentist, that's a lot longer travel to get to a dentist that might be closer. So I'm just trying to get your views on that, and should that be a considered component?
I think what I will highlight, and if you're wanting to understand my views, and I'll say generally of Health PEI, is that we are concerned with equity across the individuals, and with that, some of the options that we would most definitely be putting forward to government is whether it is a flat or a similar rate for anybody regardless of how far you have to travel, because then it is not a matter of if you happen to be located in Alberton and need to travel to Summerside, or if you're in Surrey and you need to go to Charlottetown. It is about if you're a subsidized resident and receiving care, then you're paying the same rate no matter where you happen to be located. Mm-hmm. That would definitely be one of the options that we would put forward. A per kilometer, or how much you get subsidized, that's a different approach to equity. That would be an option that can be considered as well. There's different ways to approach equity.
Rob?
Yeah, well, I guess that's all. I just would want fairness for any of my constituents, and no matter where they are in the island. And like I said before, sometimes don't have a lot of control on the location that you wind up going. Like say, there's policies, like first available bed policies and things of that nature, and that needs to be a component. So I'd hope that you would convey that message to the government to make sure that they take that into account. So my other issue I tend to run into a fair bit is those awaiting long-term care. And sometimes they're in hospital beds awaiting long-term care, and all of a sudden they get their bills to pay, which I'm of the understanding it's the same as what they would be if they were in long-term care. But how do those rules apply? Is there any difference between if you're in awaiting long-term care in a hospital bed versus in a long-term care facility? And what the fees would be?
Not quite sure what you're referring to in the last part. If you're in a long-term care facility, then the fees would be applied. You wouldn't be having any difference.
There's no difference then. So once you're designated awaiting long-term care, you're going to be getting the same fee that you would when eventually you do become into a long-term care facility.
What I would say is this, that the Long-Term Care Subsidization Act applies to people in licensed long-term care beds. The fee structure that is used for that is based on the service agreement that we have with private nursing homes. And Health PEI has a policy where people who are in hospital cannot go home, so they don't need to be in the hospital for medical reasons, but they can't go home. So they're what is termed medically discharged, awaiting long-term care. They've tried to make the cost go down from the dollar per day value of a acute care bed, which is somewhere around $1,200, to a fee that would be similar to what they would pay if they were in long-term care. So they created a policy that we do an assessment for those residents to see what they could pay as if they were in a long-term care bed. But that fee structure is not related to the Long-Term Care Subsidization Act, because it's only for licensed long-term care beds in public and private facilities. So the cost is similar, but it's not underneath the same act.
We do apply the similar processes where if you were going to be eligible for a subsidy, even the rate that was set for a long-term care awaiting placement, it's similar, if not the same, as what our long-term care subsidy rate is that you have to meet, and it can be reduced. So I've had some individuals, they need full subsidization and they don't have any income to contribute, so there would be no charges. So it does vary to that piece.
Hey, Rob?
So shouldn't that maybe be in the Act to accommodate that, so you have a little more protection in determining those rates, to at least include people who are awaiting long-term care, or should the Act be altered to address that?
I'd have to go back and have legal look at that, because the Long-Term Care Act deals with private nursing homes. Hospitals fall under a different act. There's Hospital Services Act, so it would potentially be making it grayer. It might be a different act that would have to be looked at.
Rob?
So it would seem to me, though, we have a lot of people awaiting long-term care in hospital beds, so to a certain degree, our hospital services are doing that duty. Now, I can get that the services would be a little slightly different, things of that nature, but how many people would be awaiting long-term care that are sitting in hospital beds at the moment? Any sense of what that would be?
I don't have the actual number as of today. I didn't bring my information with me, but in the last review, I believe it was around 55, but I'd have to confirm that and get back to you.
And so the number ebbs and flows.
Yeah, no, I
on
realize.
the number of private long-term care beds that are open as well as public, just on what the flow is. Usually what we see is there'll be a dip after new long-term care beds have opened. And then sometimes we see it build back up again just due to demographics and the number of people coming online.
Hey, Rob?
So it would seem to me that that's not very cost effective if we're having people that are in a hospital bed that are $1,200 in costs versus in a long-term care bed, or whether it be private or public, that would be a lot lower expenses. So there would be some cost effectiveness that would be making sure people are designated to the right bed that they require based on their level of need, correct?
It would be a more appropriate place to care for them in long-term care, I would agree, and it would help us with patient flow, because it's not like we could close the beds behind the individuals that are awaiting. It's allowing us to flow people through, so it is more appropriate place to care for them, more cost-effective in that particular piece. You'll notice I do not say it's a cost savings because the beds are still required in the hospital.
Agreed, yeah.
Exactly.
Rob?
My final question on this would be, so how many beds are imminent of opening in the next few months? I mean, I know there was announcements made under previous government, and I think even the current government has said that there's some beds. So I'm assuming in the next 6 months, there must be a number of beds opening soon. So I'm just trying to get a sense of...
Yeah, so under the previous government, 100 long-term care beds were put through an RFP process. To date, we're still awaiting opening of 42 of those beds. And there's been delays in the 2 facilities that have been awarded those beds for various reasons. One of them being our recent hurricane flattened the construction that was ongoing for 30 of those beds, so it's delayed them significantly. And as I'm sure you're all aware, we are challenged with getting staffing for some of our clinical areas, and so the facilities are under that pressure as well. So they're actively trying to open those beds, and we believe that both will be opened this year, 2020, early summer.
So just to clarify a bit more, so we said that there's 55 awaiting long-term care in hospital beds. How many people are awaiting long-term care in other facilities or at home? I mean, once you're designated, you may not be in a hospital bed or require that.
Again, I don't have my numbers as of right today, but the number was around 157.
That would be overall total? Okay,
That's total,
that's
yes,
better.
55 being in hospital, the remainder being in home or in a community care facility waiting
Yeah.
for, some other place that would not be called a hospital.
And you hope to have 42 open in the next while?
That's right.
Okay, thanks.
Okay. Thanks, Rob. Gord?
Thanks a lot, Chair. My questions to start a little bit about supply and demand, kind of going from there. In the next 5 years, what do you think the demand on the private nursing homes would be? If they're at 1,200 now, where do you think we're going with that number?
Can I just say, to be fair, there's 608 beds in the private. We have 1,203 beds total, of which the remaining is in the public long-term care system.
Okay.
So I want the numbers correct, that's all.
Perfect. Okay.
And if you look at studies for long-term care, it's one component of care in an aging population. And so the bed projections are also contingent upon what services in home care we have, other services that rely on supporting people living at home. So it's always a trend on what that equation is. So what services can you provide through home care? What you need as a capacity. Right now we have one of the highest bed ratios in the country for long-term care beds per 1,000 population age 75 and plus. We're currently conducting a review with the other provinces to make sure that we see where we are in alignment, but we've been consistently amongst the highest proponent of bed availability. Other provinces seem to be able to provide services to the residents without going to so many long-term care beds, and maybe it's more cost effective. We're trying to understand that as we project, so we're constantly doing that. So it's a hard question for me to give an easy answer to.
Yeah, so we have to strengthen more programs like the Seniors Independence Program and
Exactly.
Home care.
yeah, home care and
Definitely.
along those lines. During this report, it says payments to private nursing homes were approximately $20 million per year at the time of this audit. So that was in 2016. Now, I think we said in the presentation there-
27.4.
Yeah, 27.4 in 2018-19. Is that about $7.4 million? Is that about where you projected it was going to be at the time?
So, Denise?
I wouldn't say that projected at the time of the audit.
Yeah.
No, because there is a chunk of that growth that was also due to the addition of new beds. So that's not something we would have been able to project at that particular piece. The other component that is within that is the amount that's negotiated with private nursing homes to reimburse them for both the nursing care services and the accommodation services and those particular pieces. And we didn't mention it earlier, but I do want to highlight that we also include in our remuneration, there's also a special fee for those private nursing homes that have designated dementia care beds. So all of that has factored into what the growth has been since from 2016 to now on those pieces. So it's not unexpected, I will say, given those factors.
I guess I'm just trying to figure out where that number ends in the next little while, or are we going to be looking at increased payments? Is that number going to balloon with, I guess I could ask about, is the amount of dollars that Health PEI is putting in per person, is that staying relatively stable, or is that increasing?
I would say it's increasing at a slightly greater rate than what the overall increases are for the funding that comes to Health PEI. There is an arbitrator's decision that actually ended up with the last round of negotiations with the private nursing homes, where the rate, the increase that was provided to the nursing homes was higher than what we had planned for. So that's something that we couldn't have predicted. It is potential that that could happen again. It is for the private nursing homes in their negotiations to make the case to government to support what their actual costs are, what they may be incurring. I can see some of them making the arguments or cases. I've heard of them offering special incentives to try and get nursing staff or others in. That can impact what their costs are. The other factor within the private nursing homes is there is a variety of models for how they approach it. There are some not-for-profits, there are some for-profits, there are some cooperatives, and their costs vary greatly. So it's bringing it all together and saying then what's the average rate that gets remunerated.
Service agreement responses.
Yes.
Gord?
Okay, yeah, just talking about, we'll segue into another question about the trust accounts. If there's so much variety in the private sector, how can you get an accurate assessment of, is it accurate across the board when we're talking about the trust accounts and the financial information that's coming back to you? Is the administration piece accurate across the board would be my question.
If you mean with regards to the expenses that are charged to the trust accounts, I would say that would be accurate in what we have, because those are the expenses of the individual residents. We are not entitled under the service agreement for detailed financial records for any one private nursing home. So that is separate from that particular piece. The remuneration is, as I said, part of the contract negotiations and what the two parties between the Department of Health and Wellness and the Private Nursing Home Association, they would do those particular pieces. It's not a factor in the trust accounts.
Okay.
Gord?
And when you get that information from the private sector, is there, what happens if they're non-compliant with timeframes to you about the information about the clients?
So I think there's a bit of a misunderstanding. We get the information mostly from the client, and so then we confirm that the payments are accurate on the client-provided information when we do the reconciliations monthly with the nursing home. So the majority of the information that flows is through the power of attorney for the client or a family member who is concerned that things may not be what we think. So we get calls to review a file that way. It's not usually from the nursing homes. What we do is we take that client information, review what the nursing home provides us on that monthly basis to see when there is cases where there's some concern raised that is accurately reflected. We rarely see issues around the accommodation payments being accurately reflected. It's more around concerns that what mom's being charged or dad's being charged should be changed because it's not reflecting what really happens with their income. So it's not really many instances where I can characterize it as what you just described. It's more around a difference of opinion between what the income actually is versus what's been assessed, and that's usually between ourselves and the client.
Perfect, yeah.
The other clarification, and I'll say supplemental information that I'll add, is there is, I'll call it built-in incentives for the nursing homes to, on a timely basis every month, get their reports in on the individual and what they're doing, because they don't receive their entire payment up front. They receive a portion, and then they're within a certain number of days at the end of the month, they have to file the report in order to get the balance of their payment. Okay. So it's inherently built in for them to report on a timely basis.
So I appreciate that clarification, because when I was listening to the presentation, it sounded like the private nursing homes were going to be doing more on that file, and I was just wondering if it was. Yeah, sorry.
On the reporting in the trust fund.
Yes, yeah. So what that really was on the trust accounts. So one of the things, and for clarity, what the Auditor General's office recommended is that we do audits on the trust accounts for residents because they feel that they could be subject to, misuse, I guess, and we need to have some role of oversight. So what I did and my staff did after we received the original report was we learned how to do a audit from auditors in, a full accounting audit. And we did those in a few of the facilities, which was time onerous. It actually took 3 to 4 days per audit. And we didn't have the staff time to do that.
Yeah.
So we found some interesting stuff, and we generated some good reports. So then, when looking at the time required and the fact that the Auditor General's office said, look, doing 2 of these per year isn't going to cut it because there's 10 of them, that means that you only get to each one every 5 years.
Yeah.
So you need to do more. So we said we can't do more if we do these full audits. So then we took the approach that we tried to present in the presentation, going back and reviewing what can be done. So what we're recommending in the new regulations when they are in force is that the facilities themselves will have to present each year a copy of all transactions that have occurred in that trust account to the resident's power of attorney and the resident if they're capable, and that we will do audits annually in each facility to make sure that's what they're doing. So the facility is totally transparent to the person whose money they're keeping in trust to that person. And our role will be oversight reviewing to make sure they do it. Is that clear?
That's great. Thanks a lot for the clarification. Thanks a lot, Chair.
I'll actually just add that we're really, in particular, we're quite excited by that change in process with respect to Comfort Fund accountability. Not only does it allow us for more transparency with respect to that, but we're always looking for opportunities to promote dignity and not be paternalistic with residents. This is their money. And so having this process where we require these annual reports going back to them from the administration, we feel is a strong step in that regard. So looking forward to it.
Thank you. Corey?
Thanks, Chair. And I just want to touch on what Ravi had talked about earlier about the transportation cost. Could you kind of elaborate on, so in Kings County and Prince, residents weren't being subsidized for transportation, but in Queens they were? Is that?
They're receiving some subsidization, so I'll let Calvin give you a summary of those particular pieces, but not to the same extent, we'll say, as some that may be in Queens County. But it's on the public side, just to reinforce that particular piece. Private side, they're all being treated consistently.
Okay.
Yep.
Right. So when we looked into this, what we found was that the traditional policies for the Eastern Kings was being applied in Eastern Kings. We had those old health regions, right? And when we made the change, they were still defaulting to some of those old policies. So for instance, for Eastern Kings, what the policy was that they'd apply for social services to make sure that the transportation costs could be covered. So whenever if someone had approved medical transportation, they would make an application to the social services to see if the transportation could be covered, and it would be for a lot of these cases. So then it was being covered that way, as opposed to what was inferred in the policy was that program would be covering the cost. In some cases, the transportation wasn't covered and the individual was required to pay if they needed things like as Denise referred to, some of the uninsured medical trips were not considered necessary and wouldn't have been covered. So getting clarity on what should be covered and consistently applying is what we're really striving to do with the review through the department now.
So some of those individuals would have reached out or perhaps drawn upon their comfort allowance in order to pay for some of those travel.
Exactly.
And for context on some of the timeframes that Denise alluded to, with respect to this one, there is a budgetary implication to that. And so we wanted to, in the process of formulating a new approach based on equity, because it shouldn't matter where you live. I mean, we'll have to make sure we have clarity on what is pre-approved health travel. But we conducted and spent considerable work doing a pair of audits for several months at a time, just so we can formulate an informed assessment, because we want to be reasonably confident in whatever estimate that we're proposing or adjustment that may need to be made to our budgetary allotment. So that took a considerable period of time, because we took a couple of sample sizes of several months each, then the analysis and compilation of that to inform the approach that we're bringing forth to the department.
To get the full extent, a good sense of the full extent of just how frequently was it happening, because that was the concern, and how much we rely on other departments to perhaps provide funding, which, as Calvin mentioned, is not what was originally envisioned in the Act. So some people are still having coverage through some sort of government support or subsidies, but how do we all bring it into alignment and coordinate our work better?
Exactly.
Yep.
Corey?
Do we have an idea of how much these people that would be using other government services, do we know if they were covered, or how many people went that had to use their comfort allowance?
Can I say it this way? I never did a total of what was coming out of the purses. What we did in our audit was understand through frequency of travel. We looked at over a period of 4 months, as Andrew mentioned, where were people going? Were they going to doctors in their local area? Were they going to doctors in Charlottetown, Summerside? Were they going to dentists in the local area? Were they going to dentists in other areas? And looking at the cost of that travel, and understanding in those areas how much was being paid by the individual versus what was being subsidized. So I could go back and look at what those numbers were, but we didn't actually say, family and social services, or what's the new name now? Social development and housing, is that correct? Social development and housing. Over there. How much is coming out of their pocket? I never did it that way, so I really couldn't give you a number on that.
Corey?
When would you, did you say it was the spring you were hoping to?
We're really aiming for the spring. We would like it to be in the legislative work plan for the spring.
Okay.
Yep.
Corey?
And like, I guess right until the spring or when it's fixed, what should residents in Prince and Kings County do? Are they going to be reimbursed for any expenses they might incur?
Those will be part of the questions when we get the clarification on the policy, whether or not it's retroactive or how we deal in those particular pieces. I think all of our staff are always striving to make sure that if there's other programs that people can access to support subsidizing those particular pieces, they're doing that now.
Okay. Corey?
Anyways, I hope that they would be reimbursed if they're living in Charlottetown and getting it, then we should get it in Kings and Prince County as well.
That's the reason we're aiming for equity, yes, very much.
Can I just add this for clarity? One of the reasons why I think that happened, and this is just an observation, just 'cause people are people, a number of the clients you're referring to would have received services from social assistance previously, and their travel costs were being covered by social assistance. Because they changed locations, of housing locations, some of that didn't change when it should have. So a lot of these individuals, as I said, I don't know the number, but that's actually what happened. They moved into long-term care, their travel costs were being covered, and they still were being covered, and really it should have been covered by someone else, as opposed to not being covered to, or being covered to not being covered. I just want to make that clarity, that we found that a lot. Okay.
Corey?
But you're not sure how much?
Don't know.
Often.
No.
So there could be people that
Absolutely.
are using, but
Yes.
we don't, it might be just a couple or...
Exactly.
Yeah.
Yep.
Corey?
You had mentioned that, I wrote a note down here, there was 55 people currently in hospital beds waiting for long-term.
So,
Yep.
yeah, the last time I checked, I have to look at the current numbers, they're always changing, but it's around 55.
Okay.
Corey?
And on average, how long are they waiting?
Wow, that's a tough question. So we do an assessment on the average wait time from hospital to the first long-term care bed that they get access to. And the current number, I don't have it with me. I thought we were looking at the audit for financial reasons, so I didn't bring that data. But I believe it was the last time I checked around just under 60 days, like 54 days, I believe, but it's something like that.
Okay.
Corey?
Would you think that 15 months waiting in a hospital bed is appropriate?
I will answer that particular piece. And no, from Health PEI's point of view, it is not what we would aim for having anybody stay in a long-term or in a hospital bed. However, we do also recognize and are working with government on the challenges. Those longer-term waits in hospital tend to relate to individuals with very complex needs that require special care either in the public or the private side, and there is not as much resourcing available for that. So it can cause some individuals with very complex needs to have more extended waits. There are also some that have much shorter waits than even the 60 days that Calvin mentioned on the average. Yes.
Corey?
And I know there's only so many beds, we can't just make beds appear. But in Kings County Memorial Hospital, there's an individual that's been in there now for 15 months waiting for a bed. And the family, well, they've called me numerous times, and there's nothing I can do. There's rules and procedures of how you get into a bed. But it's just, I feel so bad because they tell me that he's just wasting, like he's deteriorating. His health is going downhill. I've been in to see him a couple of times. First, when he'd first gotten in, he knew who I was. He remembered my name. Now he doesn't even know who I am when I go to visit him. So I guess you would mention 60 days is the average, but there is someone in Montague and perhaps in other places as well that he's been in there 15 months.
Yep.
And I'm just, Robbie had mentioned, what are they paying when they're in the hospital? Are they receiving the same, obviously they're receiving top-notch care from the nurses that are there, but, they're not receiving perhaps the same programs and activities they would receive if they were in a Manor or different facilities. So I just wanted to kind of express my frustration on that because it's something I've been getting a phone call about for the past number of weeks, so.
I completely understand. I would say many people have the same frustrations even within Health PEI and within the department.
And
Corey?
I know there's not an easy fix to it, so I just, I don't want to say it's, come on, get this fixed, because I know it's not as easy as it sounds, so thank you.
You're welcome.
Okay, other questions? Carla?
And kind of to add to that, Corey, concerning is the fact that when they are in hospital, the care is different in terms of in a home, there's certain requirements for socializing and, the recreational activities. So they don't get that in the hospital, which would probably explain a lot of the deterioration because we know the effects that loneliness can have on your health. So just, yeah. So back to, again, the people waiting. So the roughly 102 people who are not in the hospital waiting beds, is there any sort of services offered to them or their family, or is there anyone who kind of sits down with them and goes through what services are available? Because I know navigating the system is a real challenge for most people.
What we can do is take away your question and provide some information back to you, because when we came today, we were coming focused on the payments to the long-term care. So this is getting into more of the long-term care program and even hospital services. So if you want, we can take that away and send some information back.
Okay, Carla?
Great, thank you. So when there's an overpayment made to a private nursing home, what is the process for paying that back?
Can you give me clarity, overpayment by the resident or overpayment by Health PEI? Because there's two various processes.
If there's an overpayment due to a Health PEI process error.
So we've made an error and we've overpaid the facility too much
Yeah.
money. So what we do in the next billing cycle, when we found the error, we actually do a negative billing and say, we've overpaid you X number of dollars, we're taking it back.
And so would that, sorry, Chair. Would that also apply if that were to happen to an individual resident?
So
We don't pay directly to residents.
we don't pay the individuals, we pay the facility for the individual. What we have found on occasions is on reassessment of the individual, their income was misstated, so an adjustment in their line 236 income has occurred. So if they pay too much, what we do is we reimburse the individual for the overpayment they made to the facility, so we directly pay them. That does happen on occasion. So for instance, a review of the taxes was done retroactively and the income was misstated, the taxes were incorrect, and their income is lower, and they had actually paid the amount that was assessed. That would be considered an overpayment they made to the facility. We pay, because we would pay the difference between what their real income is and the full cost of the facility. So Health PEI would then pay the resident back that difference, if that's clear.
So it would, sorry, Chair, oh my gosh, I'm not good at this. So it would never fall on the back of an individual to, and the reason I'm asking this question is I'm going back to different stories I've heard on social assistance, and when people are overpaid, they're made to pay back that full chunk all at once, which is impossible for them to continue living. But that wouldn't happen there would always be a kind of a negotiation in order for the individual to.
So again, long-term care payments are not like social assistance payments. We do not pay the person. We pay the difference between the person's income and the actual cost of room and board or accommodations directly to the facility. So the only adjustments can be that the income was misstated. Thank you. So when the income is misstated, we do corrections. So sometimes the resident may owe, or we may owe the resident, and we put if the resident owes, we actually ask for them to pay the adjustment. And what we do, if they can't pay the adjustment, we establish what's called underneath our Act and Regulations a memorandum of understanding on repayment. If they can't afford what they're living, it goes to their estate, and we reconcile it with the estate.
Okay. Carla?
So when there is, are subsidy levels automatically adjusted when there is a private long-term care rate change, increase? Does that make sense? I can repeat it if that wasn't.
Do you want me to answer that?
Yes.
Yeah, so basically the rate that's in the service agreement is the rate that we always use to determine the subsidy, because that rate is basically the base for the calculations I gave you earlier. So for instance, this year it's $92.10 a day. Let's just say it changes on April 1st to $94 a day. That's just a number I pulled out of the air. The calculation would be based on 94 times 30.42. And then we look at their income and we pay the difference between their actual income and that new calculation. So it's adjusted proactively when the rate changes.
Okay.
Carla?
So I was reading through some articles, and this may not, if this is kind of out of the scope, just let me know. But in December 2019, Health PEI decided that long-term care facility operators will no longer sit on the Community Care Facilities and Nursing Homes Board. And I'm wondering what the reason was for that decision. That's probably out of the scope, isn't it?
It is outside the scope of this, and it's actually outside the scope of Health PEI.
Okay.
So that is within the realm and the mandate of the Department of Health and Wellness. They oversee the administration of that board.
Okay.
Carla, any other questions? I'll come back to you.
Yeah, come back.
Okay, Natalie?
Great. Thanks very much for your presentation today. I'm thoroughly enjoying it. I'm thoroughly enjoying all the questions from our committee here. They've taken them all out of my mouth, to be honest. So I do have a couple general questions for you, and they too might be out of the scope, and certainly no pressure to respond with details. But just in terms of painting a picture of how baby boomers are impacting the future of long-term care. Are you able to kind of give some insights around that, or?
I would say that one is outside the scope of what we came
Sure.
prepared for in relation to the
Yeah.
private nursing homes audit.
Yeah, no, that's
So
fair.
we can add that as a takeaway and send
Yeah.
some information back to the committee.
Absolutely.
Natalie?
Thanks, Chair. And this question relates back to some of the questions that Corey was asking. What type of criteria is being used in the selection process to move individuals into from hospital to long care beds or outside of hospital to long care beds? Are you able to comment on any of the criteria again?
So when you say selection criteria, you need to be assessed as needing level 4 or level 5 care.
Yes, yeah.
And then we basically, unless there's urgency or pressures on the hospitals, we go on a first come, first served basis. So
Okay.
we try to be fair and equitable by using how long you've been waiting as the main criteria, unless, as I say, someone's in crisis in home or a hospital's in such pressure that we need to do something for them.
Okay.
Natalie?
And to help promote equitability, I'm not sure if that's a word actually.
okay.
Equity in the process. Each county has a centralized intake as respect to that. Every homes don't make their own determinations. They can influence it, but they don't make determinations on who comes in and who comes out. Essentially, their different homes will have different levels of specialty potentially, especially as it relates to psychogeriatric care, dementia. But there is, each county has a process that has criteria that's established, and different stakeholders are around the table to ensure that due diligence is given to every applicant that comes forth that meets the criteria, as Calvin mentioned.
Okay. No,
Natalie?
that's very much appreciated. Yeah, it's concerning when you hear the discrepancy between the 60 days and then the 14 months or whatever it was. So no, anyway, I appreciate your time and your answers there.
Okay. Any other questions? Carla?
I just skipped one of my questions. I'm wondering if Health PEI has ever considered basing eligibility. We talked earlier about the two spouses, so one in care, one in not. If there's ever been any consideration done to not consider the spouse who's not in care's income and kind of leave them separate and just look at the individual who would be going into care?
So one of the things that we at Health PEI try to remain cognizant of is that we're responsible for the delivery of policy as set by the department. So ultimately, that is a policy question for the Department of Health and Wellness in that particular piece.
Thank you.
Thank you.
You're welcome.
Any other questions, Carla? Okay, I just have a few questions. So I'm just going to go on there, but I understand it's a policy question, but I'm going to go back to the criteria of looking at line 236. Is there, so we talked about marital status. the line 236, so you would file your taxes as married or separate or single.
Right.
So after you look at line 236, what criteria do you look? You said that you did look at if they were married or if they were single. What do you actually look at there? Can you just unpack that a little bit for me?
Yeah, so we don't look at whether they're married or single. We look at whether they have a spouse or if they are single. So it's
Okay.
you declare your status. It's not how you file your taxes. And we define spouse as if you've been in a relationship, as if you were married with someone else for 1 year or more. That's our definition. So when we look at line 236, if you define yourself as having a spouse, we took it both third incomes on line 236, add them together, divide by 2, and each one is 50%. So that's what we call their actual income, is 50% of the combined income. And then we go through a process in the variance. If they say that they can't meet their monthly expenses with half the income, then we do that justification process of looking at their actual expenses to determine if we can vary the split of the income from 50-50 to allow more of the income to be retained at home. And there is a large number of criteria. There's 4 that are associated with numbers from social assistance. So the food allowance, those sorts of things are from social assistance. But because we need to have a reasonable standard of living, we developed costs associated with living within PEI through the mean basket measure to say how much does it cost to operate a car, how much does it cost to do X or Y. So we have a predefined values for those, and we run through a formula within our system to look at that individual, their costs, and then calculate whether or not the 50-50 split has to occur, or do we allow more of the income to stay with the spouse at home.
Okay, thank you.
Does that help?
It does. However, so if the spouse at home is not on social assistance, if they're not part of the program, is there consideration given to that based on their income based on 236? They don't have any social assistance programming. They're not part of that I guess program at all. If once you take that balance 50-50 and you look at it, is there times where the spouse at home would be forced into social assistance, or do you look at that from a wholesome view?
We wouldn't, through the variance process,
Yeah.
we wouldn't force someone into the situation of having to seek social assistance.
Okay.
That's what the variance
Is all
is
about
there for, is to
Prevent.
avoid those situations, to say, if you have income of X through your own means, and you require this amount for food, housing, you might have medical expenses,
Yeah.
a car, then we need to leave you with enough to allow you to do that without having you to go and apply for social assistance.
Okay. And is that on an individual basis? Because I'm just thinking somebody could be living in a home where they've already paid it off because they've lived there for 60 years versus somebody who might be in an apartment who has a monthly. Is it looked at from an individual basis?
Very much.
Okay.
Yes, yeah.
Okay, thank you. So I just wanted to go back to the comfort subsidies. Is there a well-defined list of what qualifies to be charged under comfort charges?
Yes, each facility has a appendix to the contract that specifies what the personal uses are for the comfort allowance. So it's actually in the contract for the facilities, and the individual families are given a copy of what the usage is for the comfort allowance. What does personal use mean? So it's defined so that what they can use for it and how they access the fund.
Okay, and does that change based on the facility? So do they have different lists, or that is the list?
That is the list.
Okay. And, sorry, I wrote on a lot of different things. So you mentioned how many were currently on the wait list, and you said 157, 55 in hospital. Do you know the spread of where those 55 would be? Is there, based on the hospitals or where those are?
We don't currently have the numbers here with us, but we do
Okay.
track it by region and I believe by hospital.
By hospital, by region, by whether you need dementia care or whether you need regular long-term care. We do a detailed analysis every month.
Okay. And I mean, there's some times where private nursing facilities will not take certain types of patients. For instance, somebody who's receiving dialysis at home. And if they require long-term care, then they're in a hospital bed. Do you look So if there is any of those defined medical issues, do you look at who provides beds and where there might be, I guess, the type of care required missing across the board, and then help that define what kind of beds you need to develop, you need to make allowances for in the future when you're building?
It's very much something that we also are looking at on a system-wide basis. I know Andrew and his group are currently working on what we'll call the long-term care bed strategy, is that if there's more appropriate to have that capacity within the public system for more complex cases, how we build that capacity there, and the private nursing homes, if they're better able to cope with, we'll say, less complex patients, which is what we're seeing as the pattern. So that's what we're looking at right now and developing a plan to bring forward to government.
Yeah, like as it stands now, the placement committees would have a picture of the different bed profiles that the homes would have. So for example, we have some homes that specialize in dementia care services. We have some homes that actually have beds that are designated for those that have bilingual needs. And so we had set up recently within the last year in Prince County, for example, a bariatric center for excellence in Summerside, and also Tyne Valley as well. And another place that cohorts younger residents. So we have these tiering, and we certainly we're looking at the trends and to try to make sure that as these complex cases continue to come, that we can minimize the amount of times that people are waiting in the hospital for the extent that they are, because usually it can be very complex and problematic, and so we want to try to get ahead of that curve to the extent we can. So that's the work that's been going on.
Can I also add that no facility can reject an individual? The committee, we have admission committees that are under the auspices of Health PEI. I am the provincial chair of those, and there's 3 committees that sit, 1 per county, and they review the person's needs, and then they determine if the bed's appropriate. So it's not the facility that has the right to reject, it's making sure the individual's needs can be met in the facility. So it's different than in community care facilities. I always like to correct that point, because community care facilities have the right to accept or reject any resident they choose because they're private businesses. The contract within private long-term care homes gives that sole capacity to Health PEI through our admissions committee. So they can make a discussion as to why someone may not be appropriate, but they cannot accept or reject somebody. It's discretion of the committees.
Okay. So we do keep monitoring those things to identify the trends, to your point.
Okay. You spoke to, and I don't know where I wrote this down because I was just writing things as you were talking through, but one of the areas, so I do appreciate when you come in and you identify whenever there's IT components to something, because I recognize that engages another department and it engages requirements. So, and I do know the last time you came in and presented to us, you had actually taken a bulk of your hours to work on the out-of-province medical costs, so I appreciate that. And so now you're looking at the batch queries and the auto uploads. One thing I find interesting when I go through an AG report, it seems to spark ideas about how can you make efficiencies within the system. So when she identifies something like, adequate documentation regarding the applicant's income, it almost sounds like there's a think tank that happens that says, so what can we do in order to fix this, and what other things can be fixed to help that? So you mentioned going from 2.5 hours to do an audit down to potentially an hour to an audit, which is substantial, I think, financial savings based on the fact that I don't know what percentage of our budget is wages. It's over 50% though, so I can appreciate that. Do you take those ideas, because I know you've done it in the last one for the out-of-province medical payments, do you then take those ideas from the Auditor General and look at other areas in which you could possibly impact efficiencies through IT upgrades and come up with like a wish list or put forward information? I guess carrying forward what she identifies into other areas.
Sure. What I'll share with the committee is overall, one of Health PEI's strategic priorities, if you look at it, current strat plan that will be renewed later this summer, is innovation and efficiency. So this is a source of inspiration, but we also, this being the Auditor General's report, but we also have staff that bring forward ideas on how can we look to technology and do improvements. So what we do is, as those are brought forward to us and we identify those pieces, we work to incorporate those into our management planning process and bringing it forward to government on what would be our priority investments, whether it be on our management plan that's going underway right now. We saw the budget consultation process announcement come out. Also, when we look in the fall to do our capital budget submission to government, it also takes into consideration if we could have some technology enhancements in order to improve efficiencies. So we incorporate it in both places. Yeah.
Okay, that's good to know, because I think anytime that you can take, you know, months of work that the Auditor General does and apply that to either another department or another area within the same department, I think that that is, you know, just efficiencies, right, that we should be applying so that we can actually free up manpower or revenue or money to be able to put somewhere else where then we can apply that same kind of a thought process. So you've identified that fall of November 2022 is when you expect to have 2020, I think that came out as 2022, but at 2020. When it came to reviewing the trust accounts, you had said that you were going to have the facilities audit the individual accounts, not audit, review, and then provide the statement to, and then, but will you still continue to do your full audits at the facilities, or that will be removed?
So the information will come to both the resident as well as Health PEI, and then there will be a trust account review process so that we can do a number of facilities each year to review their reporting and verify its accuracy. That's, I believe, what we will be aiming for to continually do. It's not going to remove that. There will still be components, yep.
So you'll still be doing the audit and not, go ahead.
Can I say we'll be doing reviews, because I learned a lot, I'm not an accountant, I learned there's a significant difference between the word audit and review. So we're currently working with one of our accountants to refine the review process we'll be using. And we know that the audit process that they taught us how to do was quite onerous. So we're not going to be doing that standard. We're going to what's determined as, well, Denise is an accountant, she would tell you what a review standard is. That's what we're trying to do.
Yeah.
Okay.
So the review standard, in looking at it, we deem to be appropriate, and in conversations with the Auditor General's office and looking at it, the trust accounts don't need a level of verification to what an Auditor General would do for the financial statements. That takes a significant amount. We can still meet the objectives of ensuring that it's being appropriately utilized by using a review process, and it is accommodated within accounting standards as well.
Okay. So I'm going to jump into that. You made a statement in your presentation that had to do with the 2010-2011 numbers and filing.
The report?
Yeah,
yes.
And the filing in the House. And can you just go through that again for me? The AG had pointed out something, but you had wanted to identify that it, the numbers had not been filed within.
Well, perhaps I can comment on it. So in one of the, it's some of the things you learn. So one of the things that we had done when we reviewed the regulations way back prior to the Auditor General's report is we realized when talking to the department that Health PEI was responsible for conducting the annual reports, not the department, which was my assumption from 2007. So we started to compile a report on what we were doing within the confines of the Act in 2010, 2011, and we were generating these reports, and we were sending them, it's a different structure at that time, but sending them along and not really thinking that we were accountable to have them tabled. So when the Auditor General came in and said, well, these reports need to be tabled, we then did a review saying, well, what's happening? Why aren't these reports being tabled? So we conducted a review of how we should do that and strengthened the process from when I create the draft through going through Andrew and to Denise and to the department. So it's formalized and we have a good process now of ensuring they get tabled in the House. So it was really, I thought I was doing honestly what was required and
Right.
realized the process wasn't all there.
It didn't get to the final steps of being
Yes,
tabled.
yes.
Okay. And then I think that's all my questions. Does anybody else have any questions before we, okay. So on February, actually I do have one more question, sorry. On February 1st, you said this weekend that the review, that Health PEI should periodically review the trust accounts of subsidized residents and that you will implement that on February 1st. What caused you to not be able to introduce that until Monday when the original audit was done in 2016? What was your challenges there?
So do you want to walk through some of the, we prioritize recommendations is the first thing I'll say, and then turn it over to Calvin. And then some of what I described during my presentation is the processes that we worked through in order to say what are some of the other solutions before we get into changing regulations, what can we do within staffing resources? Because as you're aware, it's a
Right.
fairly significant piece of work to change regulations or the act, so we usually want those to be the last pieces we have to do. But Calvin can describe some of the pieces of work that we took between 2017 really and now.
Sure. I'll say this, that the February 1st timeline came out as a work plan in terms of when the regulations may become enforced. We don't know that until they actually do. So it was actually a date that we had in a work plan. So that was our target. So once the regulations actually are in place, we can deal with the stuff that says February 1st onward. So it was just data in a target work plan I had. So what we tried to do when we looked at the Auditor General's report is prioritize what we could do within the program, what couldn't we do, and what required changes to regulations and acts, and prioritize them that way, then work with Health PEI and the department over a number of different iterations to figure out how we could continually moving this work forward. In the time when Dr. Michael Corman was part of the department, this was part of the work plan, was to look at the AG recommendations, how we could implement some of those. So the report that came out of that work, which I never remember the name of it,
We just call it the Seniors Health Strategy.
we call it Seniors Health Strategy, but that's not the name.
The Seniors Health?
Yeah,
Seniors Health Strategy, but that's not the actual
Action plan
name.
for seniors health.
Yeah, so that was part of the work that was part of that, to see how we could prioritize some of that, and we recognized in that work, again, that regulation changes would be needed. So it ended up, the delay was really in the work that needed regulation changes to continue on. So in our plan now, as Denise had said earlier, we are pending a regulation change, and once they're enforced, the rest of the stuff we put in the table can occur. Okay.
All right, thank you. Okay, all right, so I don't think we have any further questions. So on behalf of the committee, I'd like to thank you for coming in, and I know you took a lot of questions and a lot of time with us, so I appreciate that. And we will take a short recess just until before we continue on with the rest of the agenda. So thank you very much, appreciate it.
Thank you.
Right, thank you. We're going to continue on. We do have some correspondence to review. So we received correspondence from, this one first? Sure. Yeah. We received correspondence from Dan Campbell, Deputy Minister of Finance, providing an action plan towards the implementation of the recommendations of 2019, the procurement of goods in government departments. So we're circulating that response and that action plan. So I'm not sure if we've had a, when did that get sent out originally?
January 22nd is when I emailed it to the committee.
Okay. So at this point in time, does anybody have any comments that they want to make on that action plan? I mean, we can always leave it open for another meeting as well. If there's anything you want to flag or talk about. Okay, and then the second letter is a January 24th letter from the Auditor General in response to the committee's request for her briefing notes on its November 13th, 2019 meeting. So I will say that was an in-camera meeting. And so we had asked that she provide just some notes to us based on that presentation that she had provided that day. So I won't go into that further based on it being in camera, but that information was provided to us. Any other questions? No? Okay. So next we have the RFP and report on post-tropical storm Dorian. So Ryan has provided us with the RFP. Does anybody, that's what it is, right? So this provides the details that we were asking for in the last meeting that we had based on what would be included in the report. So that was just circulated on, when was that circulated?
Last week. I can't remember the exact day.
Late last week. So is there any comments, Gord?
Yeah, no, this is great. And I was just on page 2 of that. Just wanted to bring it up for discussion with the committee. They have about 3/4 of the way down the page. The RFP does not directly call for an estimate or calculation of Dorian's financial impact to Islanders. Several specifications have financial aspects. For example, the areas inquiry into the companies expected to examine and make findings or include. So with that, does that mean that they're not going to look at a financial review of that? And would that affect this committee's guests in the future? Because I think that's an important aspect of any review.
Well, we can have a conversation about that. What's everybody's thoughts on if the RFP isn't directly calling for an estimate? Did we get a date as to when? Was that in the report?
July 17th. It's going to be, should no later than July 17th. Is that what?
Sorry, that's
It's
on,
going to be
there it is right
completed,
there.
2020.
So how does the committee want to go about next steps? So if the financials aren't going to be aren't going to be part of the RFP, what's everybody's thoughts on that? Rob?
I think from my perspective, I think we should eventually, I'm not saying we have to get it through the RFP to find out how much the cost of Hurricane Dorian was to Islanders. I mean, and I'll say it does mention that it may have some aspects of the monies and costs based on whether to bring in the Canadian Armed Forces, which I think is a key component. But, when we look at, there's direct costs and then there's indirect costs. And I use the example of, there may be direct costs with power lines and things like that you may get some information on. But the indirect costs are, like if I take the impacts to our forestry industry, maybe our aquaculture industry. So it would have been nice to whether we can get some impacts, whether it's from another minister or another department, to the impacts it might have on forestry. And I'd have to assume that those particular departments must have some sense of calculations. I don't think we're necessarily looking to the penny or the dollar, but to have some impact on what it would have on the industry and how many acres of trees have been lost or productivity in the aquaculture industry from the fishing side of it, or farm community would have some information, I'm assuming, through crop insurance and their request to the advanced payment program or things of that nature that might be aspects. So I'm not necessarily looking for, but I think as a committee, we should have somebody should have a general sense of what the impacts of Dorian were.
Anybody else have any thoughts on that? So the RFP is due in July. So how do we feel about that timing to see when the RFP is completed and that report comes out, to see what components are actually in that before we reach out to any of the other departments, so that we're not asking people to duplicate work? Would you, Rob?
Well, I guess the point, we don't want to duplicate things, so we don't, don't have a committee or an RFP that a company's doing a review on. And I mean, they are directly stating that it isn't the RFP, so you can't ask that company to do more than what it's bidded on in the RFP. But I would say that I think as a committee, we do have the right and obligation to find out what the impacts were of a catastrophic weather event that had big impact on islanders, and if we can have the authority in the future. So once we get the RFP, maybe that'll tell us where we have to go further, but I certainly would want to know more.
Okay.
And I would just say that we should keep an alert on considering bringing in the Minister of Finance or the person in charge of the financial aspect of it, which would be the Minister Thompson, potentially, to keep that in the mix, because if the other committee that we're on will be looking at this tomorrow too as well. So I think that this committee should have a mandate to kind of look at the financial aspects of the hurricane, and so we have to keep that in mind too moving forward, I think.
Yeah, I will just, and I don't know the section, but there is a section around this committee where we don't call typically ministers. So I think we would have to discuss, it would be more at the working level, so deputy minister, just to make sure that we are all understanding of who this committee calls as witnesses. But I think that's fair. Does anybody else have any comments or anything that they want to add? So is everybody in agreement that we wait for the RFP to come out? We'll review the findings in the RFP, and at that point in time, we will decide who else we need to hear from and what information's missing. Okay? Everybody in favor of that? Okay, perfect. So that was all the correspondence. Did anybody on the committee have anything further that they received for correspondence? No? Does anybody have any new business? Okay. And so I'll call for a motion to adjourn. Rob Henderson. Have a great day, guys. And gal.